All right, well, good morning. Why don't we go ahead and get started? This is our last grand rounds of the calendar year. Hopefully everybody is getting geared up for a wonderful holiday season, and it's our pleasure to have our own Dr. Jeff Norton speak to us this morning on gene-directed surgery. So
thank you. So I've been blessed with doing gene-directed surgery, two different types. One for the RET gene with medullary thyroid carcinoma and multiple endocrine neoplasia type 2A. When I was at Washington University in St. Louis, I was like with the first group with the pediatric surgeons to do total thyroidectomy for that. But I'm not going to talk about that today. I'm going to focus on gastric cancer, which is all this work was done here at Stanford. So gastric cancer is the second most common cancer in the world. In the United States, there's 22,000 cases and 13,000 deaths per year. It's about 6 per 100,000. The incidence is actually declining, but proximal gastroesophageal junction tumors are increasing in incidence. The average age of onset of gastric cancer is between 55 and 60 years, and the overall 5-year survival is only 5 to 15%, so it's a very lethal type of cancer. There is a familial form of gastric cancer. About 10% of patients exhibit familial clustering, and about 2 to 3% have an autosomal gene inheritance pattern. So that's what we're going to talk about today. That's hereditary diffused gastric cancer, which is actually signet ring cell cancer, which people call Linitis plastica as well. It's the most malignant form of gastric cancer. Well, an important thing for surgeons is that surgery is still a major potentially curative modality for gastric cancer. So surgery is very, very important in the treatment of it. Hereditary diffuse gastric cancer composes only about 3% of gastric cancer. It was first described in 1998 in the Maori tribe in New Zealand. It's inherited as an autosomal dominant trait. It's early onset gastric cancer in that it occurs at a young age, relatively young age. The gene has been mapped by linkage analysis to 16q22.1. It's an E-cadherin gene, CDH1, which is a trunking germline mutation. So it's important that it's not a missense mutation, it's a trunking germline mutation, and it makes E-cadherin inactive. The penetrance is about 70%. So unlike medullary thyroid cancer and MEN2A, where 100% of patients are going to get that, the predicted amount of patients who will get it is only 70% for a CDH1 mutation. So it's a little controversial whether you want to do a prophylactic gastrectomy and have no tumor in the specimen. So CDH1 is a member of the E-cadherin pathway. It's a calcium-dependent cell adhesion molecule. It's expressed primarily in epithelial tissues and involved in intercellular connections and communications. It's localized to the adherence junction on the basolateral surface. And a loss of function, when you have a mutation in CDH1, it's a loss of function. It predisposes to contact inhibition, cell adhesion, and unregulated cell growth and invasion. So with CDH1 in hereditary diffuse gastric cancer, most mutations are frame shift truncating mutations. So the missense mutations of a single base pair occur, but they do not predispose to cancer. Only frame shift mutations result in little or no immunoreactive E-cadherin protein. And the definition of a frame shift mutation is a genetic mutation caused by indels, which in this case it's deletions of a number of nucleotides in a DNA sequence that is not divisible by 3. It shifts the way the sequence is read, and for E-cadherin, it makes it inactive. So when I first came here, Jim Ford had the idea, he's the one who did all the background on this and knew exactly what was going on. He's in the Department of Medicine and Genetics. He wanted to have a protocol to treat patients with CDH1 mutations to kind of investigate them with the state-of-the-art equipment. In other words, try to determine if we could actually diagnose the cancer preoperatively and then do total gastrectomy. So Jim Ford initiated the protocol. Myself, I'm on the protocol. Yuri Ladabom is on it from gastroenterology, Brooke Jeffrey from radiology, and Terry Longacre from pathology. So this was a real prospective study, which is still ongoing. And the recommended surgery as part of this protocol was total gastrectomy. Obviously, patients could accept it or deny it. They can still be on the protocol, but total gastrectomy, and we originally recommended a D2 lymph node dissection and a Roux-en-Y esophagojejunostomy. So this is the anatomy of the stomach, and it's important to know what we mean by a D2 node dissection. We took the left gastric artery at its origin. We took the right gastric artery at its origin. We protected the common hepatic artery, and we took all the lymph nodes along the lesser curvature. We took all the lymph nodes from the hepatic flexure to the splenic flexure in the greater omentum, and it's important that we actually did a total gastrectomy in each of these patients. So I'm just going to give you a history that the typical patient, how they present. This is a 52-year-old woman from a family with a high incidence of gastric cancer. She was found to have a mutation in the CDH1 gene. It was a truncating mutation. Her 22-year-old son, who's a construction worker, also has the same mutation. Neither the patient nor her son have any symptoms at all. No indigestion, no trouble eating, no weight loss. The diagnostic workup of the mother, we got a CT, which was negative. A PET scan was reported to be positive in these patients when we started the study, so we got PET scans on every patient. It was negative. We got an upper GI endoscopy with random biopsies throughout the whole stomach, just multiple biopsies. There were no lesions seen, but many biopsies, 12 to 14 biopsies were taken, and they were all negative for any cancer. She also had an EUS of the stomach, which was negative, no wall thickening. Because these patients also get lobular carcinoma of the breast, which I didn't mention, the incidence of them getting lobular carcinoma of the breast is about 20 to 40%. So in women, we always get a mammogram, and we also get an MRI of the breast, which were also negative. The workup of her son, he had a CT similarly, which was negative, a PET scan, which was negative, similar upper GI endoscopy with 12 biopsies, which were all negative, and an EUS of the stomach, which was negative. So neither of them had any clinical evidence of gastric cancer. But they did have the mutation, and they had a strong family history. So after talking to both of them, the mother accepted surgery. She wanted surgery. One of the rules we used was we wanted to do the surgery 5 years younger than the most youngest patient in their family who developed gastric cancer. The family incidence of gastric cancer was in the 50s, so the mother made that criteria. The son actually refused surgery. He didn't want surgery. He works construction. He felt that it would be life inhibiting. This is actually the specimen from the mother. You can see that it looks entirely normal. So, you know, it's kind of hard when you do a gastrectomy, take out the whole stomach, and it looks normal, it feels normal, everything looks normal. However, there was a small signet ring cell adenocarcinoma. The signet ring cells are these clear cells, which are actually right there along the epithelial junction. They're in the wall of the stomach. This was read as a signet ring cell carcinoma, and when Dr. Longacre, who deserves a lot of credit, I mean, she developed the whole pathologic system for this. This patient actually had multifocal in situ and intramucosal invasive signet ring cell adenocarcinoma of the stomach. The largest focus was 3.5 millimeters. We took out 21 lymph nodes. Each of them had no tumor. All the margins were negative for tumor. She was staged as a T1N0M0 adenocarcinoma of the stomach. She had no other treatment. At 5.5 years follow-up, she was doing well. She did lose 55 pounds. She was overweight a little bit to begin with, but obviously a significant weight loss, and we also give them vitamin B12 shots. But there's no evidence of recurrent gastric cancer, and she has not developed lobular carcinoma of the breast. According to the protocol, she gets mammograms and also MRI of her breast every 6 months. So we're pretty vigilant about looking for that. The son, we only have 3-year follow-up on the son. He works construction. He's actually normal. He's been healthy for the 3 years since he refused surgery at age 26 now. When we started this protocol, if we look at the literature, the results for total gastrectomy in these families, there were 10 CDH1 mutation carriers reported from 3 different families. This was throughout the whole literature that underwent prophylactic gastrectomies. All were asymptomatic and had negative endoscopic biopsies and also no evidence of tumor on endoscopy or gastric biopsies. All but one had gastric cancer identified pathologically. So remember, we felt that there was about a 70% probability that they would have gastric cancer in the specimen, not 100%. And then if we looked at all, these are from the Maori reports, 476 individuals from Australia, 11 different families. In men, the gastric cancer incidence with total gastrectomy was 67%. In women, it was 83%, and the chance of developing lobular breast cancer was 20 to 40%. And in the Maoris, they develop at a young age. 32 is the average age that they develop it. And these are all the data we had before we started the study. So our protocol was the following. So we would do genetic counseling and testing for the CDH1 mutation. If they had the mutation, with a truncating mutation, they were eligible for the study. They would get annual mammograms and breast MRI for women and biannual endoscopic surveillance of the stomach. EUS, they did chromoendoscopy. There's a person named Dr. Fitzgerald in Cambridge, England, and she's developed this chromoendoscopy and biopsies for these tumors. Her protocol is what we use now for trying to find the tumor preoperatively. And they used new imaging modalities as they were developed, this Fujinon high magnification endoscope, the Olympus endocytoscope, confocal microendoscopy, and PET-CT. PET-CT had been reported to be positive for cancer in these in asymptomatic patients. And we also got every patient involved with dietary counseling, nutritional counseling, and also how to eat after a prophylactic gastrectomy. Jamie from nutrition has actually been very good at helping us teach the patients how to eat. They get confused on the morbid obesity surgery protocol, and that was a problem initially, but subsequently it's been much better. And we've had a good, quickly eating post-operatively, actually doing pretty well. And blood and tissue collection for research protocols. And this is the original family we investigated. They're the Bradfields. And these patients had the following map for cancer. You can see that it was originally in the mother, and she had 8 children. 6 out of 8 had hereditary diffuse gastric cancer. And there's a grandson that also had hereditary diffuse gastric cancer. So these patients were all screened, and this is the first family we had. So there were 6 of them, and we did the surgery on each of these patients.
Matt, first, what would you do if you discovered that you had carried a mutated gene for a very rare aggressive form of cancer and that this gene would probably lead to that cancer? Well, 11 cousins faced that very question, and they each made a very radical decision. In 1960, Golda Bradfield died of stomach cancer, leaving behind an unfortunate legacy. At least 6 of her 8 children inherited her mutated gene. The same cancer killed all of them, but not before passing the gene along to their children. 22,000 Americans will be diagnosed with stomach cancer this year. Half of them will die. For the Bradfield cousins, the risk was even higher. Through genetic testing, 11 of Golda's grandchildren learned they had inherited the gene. With up to an 80% chance of developing cancer, one by one, they decided to have their stomachs removed. Dr. Jeff Norton performed the surgery on 6 of the Bradfield cousins at Stanford Medical Center in California. In fact, Dr. Norton says each of the stomachs he removed showed early signs of cancer, signs that went undetected before the surgeries. Many of the cousins who recently reunited in Las Vegas never knew each other before their elective surgeries. Now they're bonded by common experience and the hope for a healthy future. And joining us right now, I'm going to introduce everybody. Tell me if I leave anyone out, because I have a big, long list of names. We've got Mark Allen, Linda Bradfield, Rita C. Marie, sisters Kathy Elliott, Connie Gassaway, Diane Sint, and siblings Jeannie Maccabee and Ted Specht and Bill Bradfield. Did I get everybody? Oh, okay. And Mark and Laura, we're going to kind of ask you guys to sort of speak on everyone's behalf as well. It's nice to have you all here. And let me just get kind of a sense. Everyone in the group has had surgery to remove your stomach, right? Right. And let me ask you, with a show of hands, after you had the surgery done, how many were found to have had cancer or an early form of cancer? So everybody but one of you, yeah?
Yeah, we all did.
Or at least in what doctors believe might lead to cancer, right? Anybody here hesitate about having the surgery? No, not at all. Pretty universal on that front. Laura, you cousins were not really all that close before this, your history, I guess, brought you together, right?
We were very spread out. Kitty actually lives in South Africa, and then most of the rest of us are spread out across the country. Several live in California, but East Coast.
Yeah. And your cousin David died of stomach cancer.
Yeah, David Allen. He was the one that they discovered the mutation.
A mutated gene.
Correct.
And his wife, through genetic testing, shared that with you all.
Right, once she was told that she wanted us to know that we had the possibility of possessing the mutation.
Which led to everyone going to get tested. And what do you think would have happened had you all not acted?
I feel like I might not be here now because my doctor did actually, Dr. Kubi found that I did have cancer that we did not know about, that I had no signs or symptoms. So it was very fortunate that we had this surgery, and I don't have to worry about that possibility.
And we should be clear with people, stomach cancer is deadly.
Right. Most of the time,
people don't survive.
Right. By the time you have signs or symptoms, it's too late.
And this gene was prevalent in pretty much all of the cousins, correct?
Right. 12 out of 19 in this generation had the mutation.
So, Mike, let me ask you, I mean, having your stomach removed, most of us obviously can't even imagine. What does that mean for you? What can you eat? Can you digest food properly? What's your life like?
Sure, it's really not all that different, except I can chew food a little more and take smaller bites.
And I guess eat smaller meals, kind of?
Initially, you have to eat many times a day.
Laura, do you think it's changed your life a lot?
All of us have to eat a little less sugar, which is a good thing because we've lost a lot of weight. Between all 11 of us, we've lost over 600 pounds. So we eat a lot less sugar and just a little bit slower and more often.
I know we've got a picture of you, Laura, before the surgery as well.
Okay.
So you do. Everybody in the family has lost a lot of weight because of this.
Pretty much, yes.
And I have to ask you, Laura, as well, I know through the genetic testing you have also discovered that you may have a higher risk of breast cancer as well.
In the women, we have a 39% chance of developing lobular breast cancer, so we're all trying to be very careful with that and monitor that every 6 months.
And I know you're thinking about possibly having your breast removed, again, as a preventive measure.
That's a possibility that we've all discussed, and it may be something that some of us choose to do.
Do you think, Mike, you address this, that surgery, going through this, has sort of changed your outlook on life? I mean, given your history, and you all knew what it was,
I mean, so many people in your family lost to stomach cancer that in a way you're living, I would assume, almost assuming that you're going to die from this at some point.
Many of us had that end in mind, yes.
And you? Oh, I definitely always thought I would die from that. And you just kind of live that way, thinking about it? Anybody else want to jump in? Yeah? Okay. And what about now? I know you all had a reunion in Las Vegas, kind of in an odd way, I guess you are celebrating this moment. Probably not a lot of eating at the reunion, I'm guessing, but we had a great time just celebrating every day. Every day is a gift to us. Well, it is, absolutely. Well, we appreciate you all coming on and sharing. It really is extraordinary to have so many in the family go through something like this, and we wish you all the best of health, certainly. Thank you.
So basically, Dr. Longacre actually developed a protocol to look at these stomachs after we removed them, and you can see she does extensive dissection of the stomach and labels all these things. And actually, if you look at the original Maori families, they all had diffuse gastric cancer. So some people recommended distal gastrectomy or subtotal gastrectomy. But in our study, we found that actually most of the patients had the tumors, these little yellow things. They're all multifocal tumors, and most of the patients had the tumors in the cardia. So actually that's kind of an interesting point, because we expected it to be more distal in the stomach, but they were actually more proximal. So actually, after we got this on the first 8 patients, Dr. Van Dam, who did the original endoscopy, started to do more biopsies in that area. And we did have a few patients who had biopsy-proven cancer preoperatively before we operated on them, which I think is actually a good thing. But the question really still remains whether you can actually do Dr. Fitzgerald's protocol at Cambridge, where she does multiple biopsies, or whether you need to really just take the stomach out. So that's really the question. And then if we look at all these patients, the first 6 patients, they all had signet ring cell adenocarcinoma of the stomach, multiple areas. The signet ring cells are these clear cells, and you can see them throughout the stomach. In each patient. So the first 6 patients all had cancer, and they were all from the Bradfield family. So that's the ones that were in the video. And here's another close-up microscope of that's the tumor there. So these clear cells, these big clear cells, are the tumor, and they're diffusely scattered out throughout the entire stomach. And it's actually interesting that Dr. Longacre also did immunohistochemistry for E-cadherin, and the E-cadherin on these studies show up as brown because of the positive staining with immunohistochemistry. And when you look at around where the tumor are, these large signet ring cells, there's no brown stain. So the tumor actually, the mutation causes no expression of the E-cadherin gene. So these cells can, grow on each other and grow over other tissues. So it's just like a beautiful slide of the histopathology. This is another example of it. So this is immunostaining for E-cadherin. And you can see that where the tumor is, there's no E-cadherin. So the tumor is growing like crazy within the wall. And these tumors kind of grow more within the wall. So that's why they're hard to detect on endoscopy. So this is the first patients that we did. So we actually also had patients who had symptoms. So in other words, some of the patients had some symptoms, indigestion or difficulty swallowing or maybe a little weight loss. And some of the patients were totally asymptomatic. The ones I presented to you were asymptomatic. This is the first 8 patients who were totally asymptomatic who underwent total gastrectomy. And there's a couple of important points. First of all, the tumors are actually more in the proximal stomach, and they're all multifocal. None of these patients had any positive lymph nodes, and you can see the lymph node sampling here. I don't know if you can read it, but it's between 22 and 11. And they were all staged as T1, N0. And these are the foci of tumors. Some had 3, some had 7, 4, 2, 1, 1. And then this patient had one small area here, microscopic. So these were clinical foci that you could actually detect. And the size of these tumors, the average size went from 0.8 centimeters to 1.9. So they were small tumors, just like the patient I presented. But if you look at the ones who had symptoms, and we had a similar number of patients, I think it's, let's see, 3, 5. These are 5, but I think there's 8 patients who had symptoms. You can see these patients all had very large tumors. The size of tumors, 20 centimeters, 3 centimeters, 1.5 centimeters, 17 centimeters, and 1 millimeter. 2 patients didn't have positive nodes, but all the others, T4, T3, and 1 or 2. So when they wait till they get symptoms, it becomes a very aggressive form of cancer. And these are the patients that were in the video. This is just what they look like post-op. I had a pre-op picture that shows kind of the weight loss they had, but they actually maintain their weight, you know, at a reasonable amount, and they're working and they're doing quite well. So of the first 10 patients who are asymptomatic, the ages were between 49 and 56 years, all had negative high-resolution endoscopies, chromoendoscopies, EUS, and biopsies, all had negative PET-CT scans, tumor markers. 10 of 10 total gastrectomies demonstrated multifocal, 1 to 10 millimeter intramucosal non-contiguous signet ring cell adenocarcinoma. All were staged as T1N0. All had negative mammograms, but one had a positive MRI for lobular carcinoma of the breast. And they all had decreased E-cadherin protein expression on immunohistochemistry. So Dr. Joe Forrester was kind enough to update the patients recently, and these are some data that he collected that helped me with this talk. There were 43 patients that were screened for CDH1 mutations. 8 presented with symptoms, and 35 were asymptomatic, but they presented with screening. We recommended total gastrectomy to each. 13 patients, they were asymptomatic. 30% actually declined surgery, so they didn't go on the protocol. They're just being followed with endoscopy yearly. 8 patients who were symptomatic had biopsy-proven signet ring cell adenocarcinoma preoperatively. So when they had symptoms, we could biopsy the tumor preoperatively and make the diagnosis. Of the 22 asymptomatic patients, only 3 had 14% had biopsy-proven signet ring cell cancer preoperatively. And when we did total gastrectomy, there was 1 patient who didn't have any cancer in a specimen. So 21 of 22 patients, 95% had cancer in a specimen. 1 patient had no cancer. So she had her stomach out with no cancer. If we look at the surgery results, you know, I'm kind of sensitive about the complications. There were 30 cases. No patient had any complications. There were no readmissions, and the median hospital stay was 5 days. If we look up the long-term follow-up, the median follow-up was 7 years. 6 of 8 symptomatic patients had positive lymph node metastases, and 0 of 21 asymptomatic patients had nodal metastases. All the symptomatic patients had postoperative chemotherapy. And at present, 5 of 8, 62% of the symptomatic patients have died of gastric cancer, with a median follow-up of 7 years, but it's 1 of 22 asymptomatic patients died of a non-gastric cancer related cause. And this was statistically significantly different. So, and then Dr. Forrester contacted each of these patients by telephone recently. He was able to get in touch with 15. 6 of the 15 had symptoms of bile reflux. So maybe we don't make the limb long enough, because they shouldn't, because they're all done, you know, Roux-en-Y. But each said they would do the procedure again, and they were all active and, you know, working and things like that. So in summary, CDH1 is an E-cadherin gene. Its mutations account for about 1/3 to 1/2 of hereditary diffuse gastric cancer families. Endoscopy alone is not useful currently for the early diagnosis. So there's plenty of patients who have gastric cancer who are missed with endoscopy. The tumor is multifocal. It's signet ring cell gastric cancer. In our experience, it was found in 95% of prophylactic gastrectomies from germline CDH1 mutation carriers, despite negative comprehensive preoperative evaluation. 3 patients had it diagnosed preoperatively, so it was negative in 86% of patients. And prophylactic gastrectomy had better survival than those who presented with symptoms. So if you wait until they get symptoms, it might be too late. Okay, thank you very much.